The Arkansas approach is designed to reward coordinated team-based care through medical homes, health homes, and episode-based care delivery. As we look at medical homes and health homes, the focus is really on all the healthcare and support services needed by a patient over time. So really thinking about that provider or that team that can wrap around that client and help make sure their needs are being met, both from a prevention and early intervention standpoint, as well as from an ongoing treatment and supportive services approach. In episodes, it's really focused on a specific condition, procedure, or disability. So much like we're going to talk about today, we're going to hear about the ODD episode. We have several other episodes underway, and several, in fact, this week that'll be going on, and certainly encourage you to come out and attend some of those. Work groups happening right here at UAMS, so certainly encourage you to come out. If you need more information on those, they are on our website. In both cases, in terms of medical homes and health homes, and in episodes, at the end of the performance period, we're going to look at the outcomes and see how the outcomes look for those particular patients. And then based on those outcomes, in terms of whether or not the provider was able to help increase the overall health and wellness of that client, they'll be eligible to receive incentives for providing high-quality care at an appropriate cost. In episode-based payment model, we have a principal account provider who really serves as a lead provider to help lead and coordinate that care team, as I mentioned before, who's really going to help drive the overall treatment planning and treatment development process for that particular client. In many of our episodes, the core provider may be a physician practice, a hospital, or other provider. As we've talked about within ADHD and ODD, in many cases that will likely be a behavioral health provider, but also have physicians involved in that as well. As we look at the PAP, we often think about it as the episode quarterback or contractor, if you will. I don't know about any of you, but having had some work done on my home recently, it's always helpful for me to have somebody who can coordinate across all those folks, so I don't have to deal with the person laying the tile, ripping out the tile, and going through that whole process. So it's certainly helpful to have that one person we can look to help drive that process and ultimately help drive the accountability within the episode. Similarly, they help drive the improvement across the system, again, focusing on the care coordination, early intervention, and patient education for that entire condition or diagnosis. And as I mentioned before, the focus is really on rewarding them for leading high-quality, cost-effective care. And we anticipate doing that, as we have done so thus far, through performance reports and data to help support that decision-making process. In fact, last month, we actually just released the second quarter's worth of data across the first wave of episodes that are currently in place. And just as a reminder, as we look at the principal account providers, just the process of how we select those, while we have outlined for each and every episode which providers are eligible to be a principal account provider, the actual attribution or identification process doesn't occur until the end of performance period. And that's largely because we want to make sure that we're able to see what all services are being provided, what all claims are being billed, and then from that, we'll ultimately select the provider who has the ultimate responsibility or accountability for that particular client for that episode. So just to recap, we're going to hear about the ODD thresholds in just a minute, but did want to take a few minutes and walk through some of the guiding principles that we use to help set levels for sharing thresholds or excess costs. First and foremost, our focus is on rewarding high-quality, efficient care. I think many folks have heard about the initiative and often think about the focus on how we're setting thresholds and looking at the financial aspect of it. That's important as well, but particularly as you'll hear with the ODD episode today, we also have a significant focus on quality and wanting to improve the overall quality of care, both within the health system as well as within specific episodes. Similarly, we also focus on promoting fairness, considering factors such as patient access, financial effects on providers, and changes that are required for improvement. Wanting to make sure we're helping support providers, patients, and families as we're implementing these new payment models. Similarly, we acknowledge that poor performance is a reality and should not be rewarded. To that effect, these are the incentives that we're putting in place through the episodes very much are focused on rewarding high-quality, cost-effective care and certainly helping work with those providers to help them reach that point where they can participate in gain sharing. And then fourthly, our focus is to set levels that improve the status quo and protect Arkansas from other alternatives within the healthcare system, things that we feel like don't really speak to what we're trying to do in Arkansas as it relates to transforming the healthcare system.
We want to talk a little bit about ODD, but before we get there, we want to just review a little bit about the ADHD episode, so make sure that we're all on the same page and just review where we've gone. If you look at the slide up there, and this will be probably very familiar with most of you, but we thought we should review it anyway before we go into the next episode. Of course, the episode begins with a thorough assessment of a new patient. And then once that's done, the quality assessment certification needs to be completed and sent in through the portal. And then the level 1 episode where everybody starts. And the difference is that in ADHD there are 2 levels possible. In ODD there's only 1. So there are some contrasting things that we're going to want to look at. That's why I want to present this one first. And so in level 1, the patients include ADHD only, no behavioral health comorbid conditions, positive response to treatment, or still actively titrating. I think I'll put those on so I can see better. And the treatment actually is based on evidence-based practice. It's 4 to 6 physician visits a year, which include medication with stimulants or other first-line medications, and parent-teacher behavior support. And that's the basic level 1. And the level 1 episode duration is 12 months. And then if you circle back, you can see that if you need another episode of level 1, you go back where the dotted line's underneath and do a continuing care certification and try again. Now there is a level 2, and the level 2 episode requires a severity certification to document the difference of why you need a level 2 rather than a level 1. And again, the patients would include ADHD only, no comorbid conditions, and an inadequate response to medication treatment or other complications that would come up that are well documented. And again, the treatment is still 6 physician visits a year, medications, parent-teacher behavior support, just like level 1, and the addition would be some psychosocial therapy as needed. And so this is the algorithm for ADHD level 1 and level 2. So now we're going to talk a little about ODD, and I think many of you have seen these slides too until we get into the thresholding business, but we want to talk a little bit and look at the pathway for this as well. So this is a 90-day episode. The ADHD was 12 months. This is 90 days, okay, with a single severity level and a single certification at the beginning of each episode. And this is all based on evidence-based practice in terms of what is required for adequate treatment of ODD. And again, it starts with a thorough assessment of a new patient. I still call people patients, I'm old. And then a quality assessment certification completed by the provider, which then triggers the assessment. And again, these are ODD only, no behavioral health comorbid conditions. That's going to be somewhere down the line that we will be addressing future, but this is just ODD by itself. And the treatment is 1 to 2 visits a week of behavior therapy or psychotherapy and parent-teacher behavior support. And the evidence shows that somewhere between 1 and 2 visits, so that could be for a maximum of 3 months. So the maximum would be 24 visits, and the minimum would be somewhere around 10 to 12 visits, depending. And there's going to be a great deal of flexibility built into this in terms of you deciding what clinical care really is needed. And then it goes through the 90 days, and if you need another certification, if the client has not remitted, you go back through the same process again. And this is the basic algorithm for the ODD episode. This is the episode key design. And so the episode definition is the first category, and that talks about what triggers it. An ODD episode is triggered by an ICD-9 code for oppositional defiant disorder that is not an assessment. The time frame, as we talked about, is the date of the index visit plus 90 days, and it's only a single level, as we mentioned. And then the episode includes all medical, inpatient, and outpatient claims. And post-visit, 90 days after the trigger, all claims with the ICD-9 code for ODD as primary diagnosis, at least 3 non-assessment claims, And pharmacy claims will be excluded, but we will be tracking them. And we'll be talking that in the metrics a little bit. And who can be the PAP in the episode? And this is a little bit different in some ways. It can be a PCP, a psychiatrist, or a licensed psychologist providing the majority of the therapy. And it can also be a behavioral health provider organization if the services are provided under this organization. What are the exclusions? A beneficiary who is not continuously enrolled in Medicaid during the episode, a child who is over 17 or under 6, and if there are comorbid behavioral health conditions during the episode, that's an exclusion. And the treatment volume should be episodes with less than 10 visits, have a lesser average cost than the PAP's overall average episode cost, and that will not be included in the PAP average cost calculations. Now let's talk a little bit about quality, because as Don mentioned, quality is very important to us in terms of what our patients are getting as we move more and more towards quality metrics. Now the first three on the screen are not part of the gain sharing, but they're quality metrics that we'll be looking at, and we hope you will be as well. It's the number of episodes with completed certification, the number of episodes that do not qualify as guideline concordant care. And again, we don't prescribe which EBP you use. There are a whole list of them in the appendices, but it needs to be an EBP. And the number of episodes with more than 9 visits. Now, what we will be looking at for gain sharing is the number of new episodes with medication. As we've talked about before, in the initial episode of ODD, the limit is 20% for gain sharing in the initial episode. In a repeat episode, the limit for medication is 0. That was what we all decided upon the stakeholder meeting, that it would be no medication in the second visit, since evidence-based practice really requires no medications for ODD. And the third one is the number of episodes resulting in remission, which is the 40% minimum for gain sharing. And we'll be looking at the average number of visits per episode, the average number of behavioral therapy episodes per visit, because this will all help us inform as we move towards the future what really is basic good care. Okay. Now what this shows here is the average cost distribution based on principle of accountable providers. And the graph shows the average cost plotted against providers. So each one of those blue lines is a provider, a PAP. And as you can see, the very variable in terms of cost. Ranges from somewhere around $5,500 down to about $1,000. And the average cost is about $2,100. And then you can see the percentile averages. 25th is a little about $1,500. 50th percentile is about $1,900, and the 75th percentile is $2,500. So this is what we're looking at in terms of developing gain sharing. Okay, let's move on, because the next slide is going to show this, and it's going to overlay what's acceptable and what's gain sharing, if we get that there. Okay. So this is basically the same slide as before, with the dark, because that's a blue line at $2,450 is the acceptable level, and then there's a dotted line at $1,500, which is commendable, and the light blue turquoise line at $500, which is the limit. And the gain sharing will really be between the $1,500 and the $500. But again, it's a lot of flexibility, because if you look at the $2,450, that would be the Cadillac of service. That would be 24 visits of family therapy, and the family therapy based on the Arkansas rates is $97.90. So that's almost $100, and that's where you get the $2,450. $1,500 would be could be 18 visits. That's one of the ways we looked at it. 18 visits, where 2/3 of that is family and 1/3 is group. And 500 is 10 visits of group. So again, there's a great deal of flexibility to design the program to meet the needs of the children that you're going to see with this and the families. But that's sort of where the limit is.